Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition. Chapter 5, Conception and Prenatal Development. The family before birth. A basic understanding of conception and prenatal development helps the nurse provide care to parents during normal childbearing and better understand problems such as infertility and birth defects. This chapter addresses formation of the gametes and the process of conception, prenatal development, and important auxiliary structures that support normal prenatal development. The reason for the occurrence of multi-fetal pregnancy, e.g. twinning, is also discussed. Gametogenesis. Gametogenesis is the development of ova in the woman and sperm in the man. Table 5.1. Production of gametes, reproductive or germ cells, requires a process different from formation of somatic cells or other body cells. Somatic cells reproduce by a process called mitosis. Each somatic cell has 46 paired chromosomes, 22 pairs of autosomes, non-sex chromosomes, and 1 pair of sex chromosomes, X or Y chromosomes. During mitosis, the cell divides into 2 new cells, each having 46 chromosomes like the parent cell. Gametogenesis requires a special reduction division called meiosis. Unlike mitosis, in which the diploid number, 46, of chromosomes is retained in the new cells, meiosis halves the number of chromosomes to arrive at the haploid number of 23. Only one of each chromosome pair, 22 autosomes, and 1 sex chromosome, is directed to the gamete. In addition, with the exception of the X and Y chromosomes in males, each chromosome exchanges some material with its mate, so the new chromosome in the gamete contains some material from the mother and some from the father. This process, which is called crossing over, allows variation in genetic material while keeping constant the total amount of chromosome material from generation to generation. When the sperm and ovum unite at conception, the halves form a new cell and restore the chromosome number to 46. Oogenesis. Oogenesis is the formation of female gametes, figure 5.1a, within the ovary. Oogenesis begins during prenatal life when primitive ova, oogonia, multiply by mitosis. Each oogonium contains 46 chromosomes. Before birth, these oogonia enlarge to form primary oocytes, each surrounded by a layer of follicular cells. They are called primary follicles. The primary oogonium begins its first meiotic division during fetal life, but does not complete the process until puberty. The primary follicle and its oogonium, which still contains 46 chromosomes, remain dormant throughout childhood. By the 30th week of gestation, the female fetus has all the ova she will ever have. Many of these ova regress during childhood. When a girl's reproductive cycles begin at puberty, some of the primary follicles present at birth begin maturing. The process of gamete maturation continues throughout her reproductive years until the climacteric. When the oocyte matures, 2 meiotic divisions reduce the chromosome number from 46 paired chromosomes to 23 unpaired chromosomes, 22 autosomes, and 1 X chromosome. Shortly before ovulation, or release of the mature ovum from the ovary, the primary oocyte completes its first meiotic division, which began during fetal life. The result is a secondary oocyte containing 23 chromosomes. The primary cell's cytoplasm is divided unequally with this division, and most of it's retained by the secondary oocyte. The remainder of cytoplasm plus the other half of the chromosomes go into a tiny, non-functional polar body that soon degenerates. At ovulation, the secondary oocyte begins to form a mature ovum, second meiotic division. Each of the 23 chromosomes divides without replication of the deoxyribonucleic acid, DNA. The second meiotic division is prolonged, and the mature ovum remains suspended in metaphase, the middle part of cell division. If fertilization occurs, the second meiotic division is completed, resulting in a mature ovum with 23 chromosomes and a second tiny polar body containing the 23 discarded chromosomes that degenerate. If the ovum is not fertilized, it does not complete the second meiotic division and degenerates. In oogenesis, one primary oocyte results in a single mature ovum. When the mature ovum is released from the ovary, it is surrounded by two layers, the zona pellucida and the cells of the corona radiata. These layers protect the ovum and prevent fertilization by more than one sperm. For fertilization to occur, the sperm must penetrate these two layers to reach the ovum's cell nucleus. Spermatogenesis. Spermatogenesis, formation of sperm or male gametes in the testes, see figure 5.1b, begins during puberty in the male and requires approximately 70 days to be completed. Primitive sperm cells, or spermatogonia, develop during the prenatal period and begin multiplying by mitosis during puberty. Unlike the female, the male continues to produce new spermatogonia that can mature into sperm throughout his lifetime. Although male fertility gradually declines with age, men can father children in their 50s, 60s, and beyond. Each spermatogonium contains 46 paired chromosomes. In the mature male, a spermatogonium enlarges to become a primary spermatocyte containing all 46 chromosomes. The first meiotic division forms two secondary spermatocytes and reduces the number to 23 unpaired chromosomes in each gamete, 22 autosomes, and one X or Y sex chromosome in each spermatocyte. Each chromosome of the secondary spermatocyte divides to retain 23 chromosomes in the second meiotic division, forming two spermatids. Therefore, 50% of the 4 spermatids resulting from the two meiotic divisions of the spermatogonium carry an X chromosome, and 50% carry a Y chromosome. The spermatids gradually evolve into mature sperm. The gamete from a male determines the gender of the new baby because the ovum carries only an X chromosome. Each mature sperm contains 23 chromosomes, 22 autosomes, and either an X or a Y chromosome. If an X-bearing spermatozoon fertilizes the ovum, the baby is a girl. If a Y-bearing spermatozoon fertilizes the ovum, the baby is a boy. The mature sperm has 3 major sections: a head, middle portion, and tail, figure 5.2. The head is almost entirely a cell nucleus and contains the male chromosomes that join the chromosomes of the ovum. The middle portion supplies energy for the tail's whip-like action. The movement of the tail propels the sperm towards the ovum. Conception. Natural conception is the interaction of many factors, including correct timing between release of a mature ovum at ovulation and ejaculation, semen expulsion, of enough healthy, mature, motile sperm into the vagina. Although exact viability is unknown, the ovum may survive no longer than 24 hours after its release at ovulation. Most sperm survive no more than 24 hours in the female reproductive tract, although a few may remain fertile in the woman's reproductive tract up to 80 hours. Preparation for conception in the female. Before ovulation, several oocytes begin to mature under the influence of follicle-stimulating hormone, FSH, and luteinizing hormone, LH, from the woman's anterior pituitary gland. Each maturing oocyte is contained within a sac called the Graafian follicle, which produces estrogen and progesterone to prepare the endometrium, uterine lining, for a possible pregnancy. Eventually, one follicle outgrows the others. The less mature oocytes permanently regress. Release of the ovum. Ovulation occurs approximately 14 days before a woman's next menstrual period would begin. The follicle develops a weak spot on the surface of the ovary and ruptures, releasing the mature ovum with its surrounding cells onto the surface of the ovary. The collapsed follicle is transformed into the corpus luteum, which maintains high estrogen and progesterone secretion necessary to make final preparation of the uterine lining for a fertilized ovum. Ovum transport. The mature ovum is released on the surface of the ovary, where it is picked up by the fimbriated, fringed, ends of the fallopian tube. The ovum is transported through the tube by the muscular action of the tube and movement of cilia within the tube. Fertilization normally occurs in the distal third of the fallopian tube, ampulla, near the ovary. The ovum, fertilized or not, enters the uterus approximately 4 days after its release from the ovary. Preparation for conception in the male. The male preparation for fertilizing the ovum consists of ejaculation, movement of the sperm in the female reproductive tract, and preparation of the sperm for actual fertilization. Ejaculation. When a male ejaculates during sexual intercourse, 35 to 200 million sperm are deposited in the upper vagina and over the cervix. The sperm are suspended in 2 to 5 milliliters of seminal fluid, which nourishes and protects the sperm from the acidic environment of the vagina. Many sperm are lost as the ejaculate drips from the vaginal introitus. Other sperm are inactivated by acidic vaginal secretions or digested by vaginal enzymes and phagocytes. The seminal fluid coagulates slightly after ejaculation to hold the semen deeply in the vagina. Many sperm are relatively immobile for approximately 15 to 30 minutes until other seminal enzymes dissolve the coagulated fluid and allow the sperm to begin moving upward through the cervix. Transport of sperm in the female reproductive tract. The whip-like movement of the tails of spermatozoa propels them through the cervix, uterus, and fallopian tubes. Uterine contractions induced by prostaglandins in the seminal fluid enhance movement of the sperm towards the ovum. Only sperm cells enter the cervix. The seminal fluid remains in the vagina. Many sperm are lost along the way. Some are digested by enzymes and phagocytes in the female reproductive tract, whereas others simply lose their direction, moving into the wrong tube or past the ovum and out into the peritoneal cavity. Preparation of sperm for fertilization. Sperm are not immediately ready to fertilize the ovum when they are ejaculated. During the trip to the ovum, the sperm undergo changes, enabling one of them to penetrate the protective layers surrounding the ovum, a process called capacitation. During capacitation, a glycoprotein coat and seminal proteins are removed from the acrosome, which is the tip of the sperm head. After capacitation, the sperm look the same but are more active and can better penetrate the corona radiata and zona pellucida surrounding the ovum. Sperm must also undergo an acrosome reaction to further prepare them to fertilize the ovum. The sperm that reach the ovum release hyaluronidase and acrosin to digest a pathway through the corona radiata and zona pellucida. Their tails beat harder to propel them towards the center of the ovum. Eventually, one spermatozoon penetrates the ovum. Fertilization. Fertilization occurs when one spermatozoon enters the ovum and the two nuclei containing the parent's chromosomes merge. Figure 5.3. Entry of one spermatozoon into the ovum. Entry of a spermatozoon into the ovum has three results. First is the zona reaction, in which changes in the zona, pellucida, surrounding the ovum prevent other sperm from entering. Second, the cell membranes of the ovum and sperm fuse and break down, allowing the contents of the sperm head to enter the cytoplasm of the ovum. Third, the ovum, which has been suspended in the middle of its second meiotic division since just before ovulation, completes meiosis. This results in a nucleus with 23 chromosomes and the expulsion of a second non-functional polar body. The mature ovum now contains 23 unpaired chromosomes, 22 autosomes and 1 X chromosome, in its nucleus. Fusion of the nuclei of sperm and ovum. Once a spermatozoon has penetrated the ovum, fusion of their nuclei begins. The sperm head enlarges and the tail degenerates. The nuclei of the gametes move toward the center of the ovum, where the membranes surrounding their nuclei touch and dissolve. The 23 chromosomes from the sperm mingle with the 23 from the ovum, restoring the diploid number to 46. Fertilization is complete and cell division can begin when the nuclei of the sperm and ovum unite. Pre-embryonic period. The pre-embryonic period is the first 2 weeks after conception, figure 5.4. Around the 4th day after conception, the fertilized ovum, now called a zygote, enters the uterus. Initiation of cell division. The zygote divides into 2, then 4, then 8 cells, and so on until the 16-cell stage. The cells become tightly compacted with each division, so they occupy about the same amount of space as the original zygote. When the conceptus, cells and membranes resulting from fertilization of the ovum, is a solid ball of 16 cells, it is called a morula because it resembles a mulberry. The outer cells of the morula secrete fluid, forming a blastocyst, a sac of cells with an inner cell mass placed off-center within the sac. The inner cell mass develops into the fetus. Part of the outer layer of cells develops the fetal membranes and the placenta, or the fetal structure that provides nourishment, removes wastes, and secretes necessary hormones for continuation of the pregnancy. Entry of the zygote into the uterus. When the blastocyst contains approximately 100 cells, it enters the uterus. It lingers in the uterus another 2 to 4 days before beginning implantation. The endometrium, now called the decidua, is in the secretory phase of the reproductive cycle, 1.5 weeks before the woman would otherwise begin her menstrual period. The endometrial glands are secreting at their maximum, providing rich fluids to nourish the conceptus before placental circulation is established. The endometrial spiral arteries are well developed in the secretory phase, providing easy access for the development of the placental blood supply. Implantation in the decidua. The conceptus carries a small supply of nutrients for early cell division. However, implantation at the proper time and location in the uterus is critical for continued development. Implantation, or nidation, is a gradual process that occurs between days 6 and 10 after conception. During the relatively long process of implantation, embryonic structures continue to develop. Maintaining the decidua. Implantation and survival of the conceptus require a continuing supply of estrogen and progesterone to maintain the decidua in the secretory phase. The zygote secretes human chorionic gonadotropin, HCG, to signal the woman's body that a pregnancy has begun. Production of HCG by the conceptus causes the corpus luteum to persist and continue secretion of estrogen and progesterone until the placenta takes over this function. Location of implantation. The conceptus must be in the right place at the right time for normal implantation to occur. The site of implantation is important because it is where the placenta develops. Normal implantation occurs in the upper uterus, slightly more often on the posterior wall than the anterior wall. The upper uterus is the best area for implantation and placental development for 3 reasons. 1. The upper uterus is richly supplied with blood for optimal fetal gas exchange, nutrition, and waste elimination. 2. The uterine lining is thick in the upper uterus, preventing the placenta from attaching too deeply into the uterine muscle and facilitating easy expulsion of the placenta after full-term birth. And 3. Implantation in the upper uterus limits blood loss after birth because strong interlacing muscle fibers in this area compress open endometrial vessels after the placenta detaches. Mechanism of implantation. Enzymes produced by the conceptus erode the decidua, tapping maternal sources of nutrition. Primary chorionic villi are tiny projections on the surface of the conceptus extending into the endometrium, now called the decidua basilis, which lies between the conceptus and the wall of the uterus. The chorionic villi eventually form the fetal side of the placenta. The decidua basalis forms the maternal side of the placenta. See Figure 5.7a. At this early stage, nutritive fluid passes to the embryo by diffusion, the passive movement across a cell membrane from an area of higher concentration to one of lower concentration. Because the circulatory system is not yet established, the conceptus is fully embedded within the mother's uterine decidua by 10 days, and the site of implantation is almost invisible. As the conceptus implants, usually near the time of the next expected menstrual period, a small amount of bleeding, spotting, may occur at the site. Implantation bleeding may be confused with a normal menstrual period, particularly if the woman's menstrual periods are usually light. Embryonic period. The embryonic period of development extends from the beginning of the 3rd week through the 8th week after conception, Figure 5.5. Basic structures of all major body organs are completed during the embryonic period, Table 5.2. Differentiation of cells. The embryo, developing baby from the beginning of the 3rd week through the 8th week after conception, progresses from undifferentiated cells with essentially identical functions to differentiated or specialized body cells. By the end of the 8th week, all major organ systems are in place, and many are functioning, although in a simple way. Development of the specialized structures is controlled by 3 factors. 1. Genetic information in the chromosomes received from the parents. 2. Interaction between adjacent tissues. And 3. Timing. Although basic instructions are carried within the chromosomes, one tissue may induce change toward greater specialization in another, but only if a signal between the 2 tissues occurs at a specific time during development. In this way, structures develop with appropriate sizes and relationships to each other. During the embryonic period, structures are vulnerable to damage from teratogens because these structures are developing rapidly. Normal development of one structure often requires normal and properly timed development of another structure. Unfortunately, a woman may not realize she is pregnant during this sensitive time. For this reason, the possibility of pregnancy should be explored with her before the prescription of drugs or administration of diagnostic procedures such as radiography. Some agents may be damaging at one time during pregnancy but not at another. Others may be damaging at any time during pregnancy. Weekly developments. Development occurs simultaneously in all embryonic organ systems. Prenatal development proceeds in patterns that continue after birth. Cephalocaudal, head to toe, central to peripheral direction, from center outward, simple to complex. Early cells may become any cell of the body before they become specialized into specific structures with specific functions. General to specific, upper extremities begin as limb buds before detailed development of bones, joints, muscles, ligaments, and fingers. Full term ranges from 36 to 40 weeks of fertilization age, calculated from date of conception, or 38 to 42 weeks of gestational age, after last menstrual period. Because conception occurs approximately 2 weeks after the first day of the last menstrual period in most women who have 4-week cycles, the fertilization age used in this chapter is approximately 2 weeks shorter than the gestational age. However, gestational age is most commonly used in practice because the last menstrual period provides a known marker, whereas most women do not know exactly when they conceived. Ultrasonography provides added information to identify the most accurate fetal age. See Chapter 9. Week 2. Implantation is complete by the end of the second week after fertilization. The most growth occurs in the outer cells, or trophoblast, which eventually becomes the fetal part of the placenta. The inner cell mass becomes flattened into the embryonic disc and will later develop into the baby. Cells that eventually form part of the fetal membranes develop. Week 3. Many women miss their first menstrual period during the 3rd week after conception. The embryonic disc develops 3 layers called germ layers, which in turn give rise to major organ systems of the body. Table 5.3. The 3 germ layers are the ectoderm, the mesoderm, and the endoderm. The central nervous system, CNS, begins developing during the 3rd week. A thickened, flat neural plate appears, extending toward the cephalic end of the embryonic disc. The neural plate develops a longitudinal groove that folds to form the neural tube. At the end of the 3rd week, the neural tube is fused in the middle, but still open at each end. Early heart development consists of a pair of parallel heart tubes that fuse longitudinally. The primitive or tubular heart begins beating at 22 to 23 days, resulting in a wave-like flow of blood. By the end of the 4th week, coordinated contractions result in the unidirectional flow of blood characteristic of the mature heart. Vessels developing in the chorionic villi and membranes join the heart tube. Primitive blood cells arise from the endoderm lining the distal blood vessels. Week 4. The shape of the embryo changes during the 4th week after conception. It folds at the head and tail end and laterally, resembling a C-shaped cylinder. A tail is apparent during the embryonic period because the brain and spinal cord develop more rapidly than other systems. The tail disappears as the rest of the body catches up with growth of the CNS. The neural tube closes during the 4th week. If the neural tube does not close, defects such as anencephaly and spina bifida result. Formation of the face and upper respiratory tract begins. Beginnings of the internal ear and the eye are apparent. The upper extremities appear as buds on the lateral body walls. Because the embryo is sharply flexed anteriorly, the heart is near the embryo's mouth. Partitioning of the heart into 4 chambers begins during the 4th week and is completed by the end of the 6th week. Ooh, a lot of tables and charts, like 3 pages worth. The lower respiratory tract begins growth as a branch of the upper digestive tract, which is a simple tube at this time. Gradually, the esophagus and trachea complete separation. The trachea branches to form the right and left bronchi. These bronchi, in turn, branch to form the 3 lobes of the right lung and 2 lobes of the left lung. Continued branching of the bronchi eventually forms the terminal air sacs, or alveoli. The alveoli proliferate and become surrounded by a rich capillary network, enabling oxygen and carbon dioxide exchange at birth. Week 5. The head is very large because the brain grows rapidly during the 5th week after fertilization. The heart is beating and developing 4 chambers. Upper limb buds are paddle-shaped, with obvious notches between the fingers. Lower limbs form slightly later than upper limbs. Lower limbs are also paddle-shaped, but the area between the toes is not as well defined as the division between the fingers. Week 6. The rapidly developing head is bent over the chest. The heart reaches its final 4-chambered form. Upper and lower extremities continue to become more defined. The eyes continue to develop, and the beginnings of the external ears appear as 6 small bumps on each side of the neck. Facial development begins with eyes, ears, and nasal pits widely separated and aligned with the body wall. Gradually, the embryo grows such that the face comes together in the midline, and the external ears assume their proper position on the sides of the head. Week 7. General growth and refinement of all systems occur 7 weeks after conception. The face becomes more human-looking. The eyelids begin to grow, and the extremities become longer and better defined. The trunk elongates and straightens, although a C-shaped spinal curve remains in the newborn at birth. The intestines have been growing faster than the abdominal cavity during the embryonic period. The relatively large liver and kidneys also occupy much of the abdominal cavity. Therefore, most of the intestines are contained within the umbilical cord, while the abdominal cavity grows to accommodate them. The abdomen is large enough to contain all its normal contents by 10 weeks. Week 8. The embryo has a definite human form, and refinements to all systems continue. The ears are low set but approaching their final location. The eyes are pigmented but not yet fully covered by eyelids. Fingers and toes are stubby but well defined. The external genitalia begin to differentiate, but male and female characteristics are not distinct until 10 weeks after conception, or 12 weeks after the woman's last menstrual period. Fetal period. The fetal period is the longest part of prenatal development. It begins 9 weeks after conception and ends with birth. All major systems are present in their basic form. Dramatic growth and refinement in the structure and function of all organ systems occur during the fetal period. Figure 5.6. Teratogens may damage already formed structures, but are less likely to cause major structural alterations. The CNS is vulnerable to damaging agents through the entire pregnancy. Weeks 9 through 12. The head is approximately half the total length of the fetus at the beginning of this period. The body begins growing faster than the head, changing the proportions. The extremities approach their final relative lengths, although the legs remain proportionately shorter than the arms. The first fetal movements begin but are too slight for the mother to detect. The face is broad with a wide nose and widely spaced eyes. The eyes close at 9 weeks and reopen at 26 weeks after conception. The ears appear low set because the mandible is still small. The intestinal contents, partly contained within the umbilical cord, enter the abdomen by 11 weeks as the capacity of the abdominal cavity catches up with them in size. Blood formation occurs primarily in the liver during week 9, but shifts to the spleen by the end of week 12. The fetus begins producing urine during this period and excretes it into the amniotic fluid. Internal differences in males and females begin to be apparent in the 7th week. External genitalia look similar until the end of the 9th week. By the end of week 12, the fetal gender can be determined by the appearance of the external genitalia. Weeks 13 through 16. The fetus grows rapidly in length, so the head becomes smaller in proportion to the total length. Movements strengthen, and some women, particularly those who have been pregnant before, are able to detect them. This phenomenon is referred to as quickening. The face looks human because the eyes face fully forward. The ears approach their final position at the sides of the head and in line with the eyes. Weeks 17 through 20. Fetal movements feel like fluttering or butterflies. Some women may not recognize these subtle sensations. The fetus is unlikely to survive outside of the uterus at the age of 20 weeks. Changes in the skin and hair are evident. Vernix caseosa, a fatty, cheese-like secretion of the fetal sebaceous glands, covers the skin to protect it from constant exposure to amniotic fluid. Lanugo is fine, downy hair covering the fetal body and helps the vernix adhere to the skin. Both vernix and lanugo diminish as the fetus reaches term. Eyebrows and head hair appear. Brown fat is a special heat-producing fat deposited during this period. It is located on the back of the neck, behind the sternum, and around the kidneys. Chapter 19, Figure 19.4. Weeks 21 through 24. While continuing to grow and gain weight, the fetus still appears thin because of minimal subcutaneous fat. The skin is translucent and red because the capillaries are close to its fragile surface. The lungs begin to produce surfactant, a surface-active lipid that makes it easier for the baby to breathe after birth. Surfactant reduces surface tension in the lung alveoli and prevents them from collapsing with each breath. Production of surfactant begins at approximately 20 weeks, but does not reach levels that increase likelihood of survival outside the uterus until 26 to 28 weeks after conception. Surfactant production increases during late pregnancy, particularly during the last 2 weeks. The capillary network surrounding the alveoli is increasing but still very immature, although some gas exchange is possible. A fetus born at this gestational age is less likely to survive because of inadequate gas exchange. Other systems are extremely immature as well, such as blood vessels in the brain that may bleed. Weeks 25 through 26. The fetus is more likely to survive if born during this period because of maturation of the lungs, pulmonary capillaries, and CNS. The fetus becomes plumper with smoother skin as subcutaneous fat is deposited under the skin. The skin gradually becomes less red. The eyes, which were closed during the 9th week, reopen. Head hair is abundant. Blood formation shifts from the spleen to the bone marrow. During early pregnancy, the fetus floats freely within the amniotic sac. However, the fetus usually assumes a head-down position during this time for 2 reasons. 1, the uterus is shaped like an inverted egg. The overall shape of the fetus in flexion is similar, with the head being the small pole of the egg shape and the buttocks, flexed legs, and feet being the larger pole. The fetal head is heavier than the feet, and gravity causes the head to drift downward in the pool of amniotic fluid. The head-down position is also most favorable for normal birth. Weeks 29 through 32. The skin is pigmented according to race and is smooth. Larger vessels are visible over the abdomen. but small capillaries cannot be seen. Toenails are present, and fingernails extend to the fingertips. The fetus has more subcutaneous fat, which rounds the body contours. If the fetus is born during this period, chances of survival are good with specialized neonatal care. Weeks 33 through 38. Growth of all body systems continues until birth, but the rate of growth slows as full term approaches. The fetus is mainly gaining weight. The pulmonary system matures to enable efficient and unlabored breathing after birth. The well-nourished term fetus at 38 or more weeks is rotund with abundant subcutaneous fat. At birth, boys are slightly heavier than girls. The skin is pink to brownish pink, depending on race. Lanugo may be present over the forehead, upper back, and upper arms. Vernix often remains in major creases such as the groin and axillae. The testes are in the scrotum. Breasts of both male and female infants are enlarged, and breast tissue is palpable beneath the areola and nipple because of maternal hormone effects. Auxiliary structures. 3 auxiliary structures sustain the pregnancy and permit normal prenatal development: the placenta, the umbilical cord, and fetal membranes. These structures develop simultaneously with the baby's development. Placenta. The placenta is a thick disc-shaped organ. The placenta has 2 components, maternal and fetal. Figure 5.7. It is involved in metabolic, transfer, and endocrine functions. The fetal side is smooth, with branching vessels covering the membrane-covered surface. The maternal side is rough where it attaches to the uterus. See Figure 12.14, A and B. The umbilical cord is normally inserted on the fetal side of the placenta, near the center. However, it may insert off-center or even out of the fetal membranes. Figure 5.8. During early pregnancy, the placenta is larger than the embryo or fetus. However, the fetus grows faster than the placenta, so the placenta is approximately 1/6 the weight of the fetus at the end of a full-term pregnancy. Maternal component. Development. When conception occurs, cells of the endometrium undergo changes to promote early nutrition of the embryo and enable most of the uterine lining to be shed after birth. These changes convert endometrial cells into the decidua. In addition to providing nourishment for the embryo, the decidua may protect the mother from uncontrolled invasion of fetal placental tissue into the uterine wall. The 3 decidual layers are: 1. The decidua basalis, which underlies the developing embryo and forms the maternal side of the placenta; 2. The decidua capsularis, which overlies the embryo and bulges into the uterine cavity as the embryo and fetus grow; and 3. The decidua parietalis, which lines the rest of the uterine cavity. By approximately 22 weeks of gestation, the decidua capsularis fuses with the decidua parietalis, filling the uterine cavity. Circulation on the maternal side. Maternal and fetal blood flow normally do not mix in the placenta, although they flow very close to each other. Exchange of substances between mother and fetus occurs within the intervillous spaces of the placenta. While in the intervillous space, the mother's blood is briefly outside her circulatory system. Approximately 150 milliliters of maternal blood is contained within the intervillous space. Blood in the intervillous space is changed approximately 3 to 4 times per minute, requiring circulation of 450 to 750 milliliters per minute for placental perfusion. Maternal blood spurts into the intervillous spaces through 80 to 100 spiral arteries in the decidua. After the oxygenated and nutrient-bearing maternal blood washes over the chorionic villi containing the fetal vessels, it returns to the maternal circulation through the endometrial veins for elimination of fetal waste products. Fetal component. Development. The fetal side of the placenta develops from the outer cell layer, trophoblast, of the blastocyst. At the same time, the inner cell mass develops into the embryo and fetus. The primary chorionic villi are the initial structures that eventually form the fetal side of the placenta. Circulation on the fetal side. The umbilical cord contains the umbilical arteries and vein to transport blood between the fetus and placenta. Chorionic villi are bathed by oxygen and nutrient-rich maternal blood in the maternal intervillous spaces. Each chorionic villus is supplied by a tiny fetal artery carrying deoxygenated blood and waste products from the fetus. The vein of the chorionic villus returns oxygenated blood and nutrients to the embryo and fetus. Capillaries in the chorionic villi are separated from actual contact with the mother's blood by the membranes of each villus. This arrangement allows contact close enough for exchange and prevents mixing of maternal and fetal blood. The closed fetal circulation is important because the blood types of mother and fetus may not be compatible. The placental arteries and veins converge in the blood vessels of the umbilical cord. 2 umbilical arteries and 1 umbilical vein transport blood between the fetus and the fetal side of the placenta. Blood is circulated to and from the fetal side of the placenta by the fetal heart. Metabolic functions. The placenta produces some nutrients needed by the embryo and for placental functions. Substances synthesized include glycogen, cholesterol, and fatty acids. Transfer functions. Exchange of oxygen, nutrients, and waste products across the chorionic villi occurs through several methods. Table 5.4. Placental transfer of harmful substances also may occur. Most substances that enter the mother's bloodstream can enter the fetal circulation, and many agents enter it almost immediately. Gas exchange. Respiration is a key function of the placenta. Oxygen and carbon dioxide pass through the placental membrane by simple diffusion. The average oxygen partial pressure, PO2, of maternal blood in the intervillous space is 50 milligrams of mercury. The average blood, PO2, in the umbilical vein after oxygenation is approximately 30 milligrams of mercury. The following 3 reasons explain how the fetus can thrive in this low oxygen environment. Number 1, fetal hemoglobin can carry 20% to 50% more oxygen than adult hemoglobin. 2, the fetus has a higher oxygen carrying capacity because of a higher average hemoglobin level, 14.5 to 22.5 grams per deciliter, and hematocrit value, approximately 48% to 69%. Hemoglobin can carry more oxygen at low carbon dioxide partial pressure, PCO2, levels than it can at high levels, Bohr effect. Blood entering the placenta from the fetus has a high PCO2, but carbon dioxide diffuses quickly to the mother's blood, where the PCO2 is lower, reversing the levels of carbon dioxide in the maternal and the fetal blood. Therefore, the fetal blood becomes more alkaline, and the maternal blood becomes more acidic. This allows the mother's blood to release oxygen and the fetal blood to combine with oxygen readily. The fetal PCO2 is almost approximately 2 to 3 milligrams of mercury higher than the PCO2 of maternal blood. However, carbon dioxide is very soluble, allowing it to pass across the placental membrane into maternal blood at this low pressure gradient. Nutrient transfer. The growing fetus requires a constant supply of nutrients from the pregnant woman. Glucose, fatty acids, vitamins, and electrolytes pass readily across the placenta. Glucose is the major energy source for fetal growth and metabolic activities. Waste removal. In addition to carbon dioxide, urea, uric acid, and bilirubin are readily transferred from fetus to mother for disposal. Because the normal placenta removes wastes for the fetus, metabolic defects such as phenylketonuria, PKU, are usually not evident until after birth. Antibody transfer. Many of the immunoglobulin G, IgG, class of antibodies are passed from mother to fetus through the placenta. This confers passive, temporary, immunity to the fetus against diseases to which the mother is immune, for example, measles. Passage of antibodies against disease is beneficial because the newborn does not produce antibodies for several months after birth. The preterm or small for gestational age infant has little protection from maternal antibodies because they are transferred during late pregnancy and are poorly transferred if placental function is inadequate. Passage of antibodies from mother to fetus is not always beneficial. If maternal and fetal blood types are not compatible, the mother may already have or may produce antibodies against fetal erythrocytes. The mother's antibodies may then destroy the fetal erythrocytes, causing fetal anemia or even death. This situation may occur if the mother is Rh negative and the fetus is Rh positive. Transfer of maternal hormones. Most maternal protein hormones do not reach the fetus in significant amounts. The female fetus exposed to androgenic hormones may have masculinization of her genitalia, and her true gender may be difficult to visually determine at birth. Endocrine functions. The placenta produces several hormones necessary for normal pregnancy. HCG causes the corpus luteum to persist for the first 6 to 8 weeks of pregnancy and secrete estrogens and progesterone. As the placenta develops further, it takes over estrogen and progesterone production, and the corpus luteum regresses. When a Y chromosome is present in the male fetus, HCG also causes the fetal testes to secrete testosterone, necessary for normal development of male reproductive structures. Human placental lactogen, also called human chorionic somatomamotropin, promotes normal nutrition and growth of the fetus as well as maternal breast development for lactation. This placental hormone decreases maternal insulin sensitivity and glucose use, making more glucose available for fetal nutrition. Steroid hormones secreted by the placenta include estrogens and progesterone. Estrogens cause enlargement of the woman's uterus, enlargement of the breasts, growth of the ductal system of the breasts, and enlargement of the external genitalia. Progesterone is essential for normal continuation of the pregnancy. It modifies and maintains the endometrium to receive and nourish the conceptus and forms the decidua. Progesterone also reduces muscle contractions of the uterus to prevent spontaneous abortions. See Chapter 6 for a more detailed list of the functions of estrogen and progesterone during pregnancy. Other hormones produced by the placenta include human chorionic thyrotropin and human chorionic adrenocorticotropin, fetal membranes, and amniotic fluid. The two fetal membranes are the amnion, inner membrane, and chorion, outer membrane. The two membranes are so close they seem to be one membrane, the bag of waters, but they can be separated. If the membranes rupture in labor, amnion and chorion usually rupture together, releasing the amniotic fluid within the sac. The amnion is continuous with the surface of the umbilical cord, joining the epithelium of the abdominal skin of the fetus. Chorionic villi proliferate over the entire surface of the gestational sac for the first 8 weeks after conception. A conceptus observed at this time looks like a shaggy sphere with the embryo suspended inside, As the embryo grows, it bulges into the uterine cavity. The villi on the outer surface gradually atrophy and form the smooth-surfaced chorion. The remaining villi continue to branch and enlarge to form the fetal side of the placenta. Amniotic fluid protects the growing fetus and promotes normal prenatal development. Amniotic fluid protects the fetus by the following actions: cushioning against impacts to the maternal abdomen, maintaining a stable temperature, promoting normal prenatal development by the following actions: allowing symmetric development as the major body surfaces fold toward the midline, preventing the membranes from adhering to developing fetal parts, allowing room and buoyancy for fetal movement. Amniotic fluid is derived from fetal urine and fluid transported from the maternal blood across the amnion. Cast-off fetal epithelial cells and vernix are suspended in the amniotic fluid. The water of the amniotic fluid changes by absorption across the amnion, returning to the mother. The fetus also swallows amniotic fluid and absorbs it in the digestive tract. Waste products are returned to the placenta through the umbilical arteries. The volume of amniotic fluid increases during the pregnancy and is approximately 700 to 800 milliliters at term. An abnormally small quantity of fluid, less than 50% of the amount expected for gestation, or under 400 milliliters at term, is called olighydramnios and may be associated with the following: poor placental blood flow, preterm rupture of the membranes, failure of fetal kidney development, blocked urinary excretion, poor fetal lung development, pulmonary hypoplasia, malformations such as skeletal abnormalities from compression of fetal parts. Hydramnios, also called polyhydramnios, is the opposite situation, in which the quantity may exceed 2,000 milliliters. Hydramnios may be associated with the following: imbalanced water exchange among mother, fetus, and amniotic fluid that has no known cause, poorly controlled diabetes mellitus, resulting in large quantities of fetal urine excretion having an elevated glucose level, malformations of the CNS, cardiovascular system, or gastrointestinal tract that interfere with normal fluid ingestion, metabolism, and excretion, chromosomal abnormalities, multi-fetal gestation. Fetal circulation. The course of fetal blood circulation is from the fetal heart to the placenta for exchange of oxygen, nutrients, and waste products, and back to the fetus for delivery to fetal tissues. Figure 5.9a. Umbilical cord. The fetal umbilical cord is the lifeline between the fetus and placenta. It has two arteries carrying deoxygenated blood and waste products away from the fetus to the placenta, where these substances are transferred to the mother's circulation. The umbilical vein carries freshly oxygenated and nutrient-laden blood from the placenta back to the fetus. The umbilical arteries and vein are coiled within the cord to allow them to stretch and prevent obstruction of blood flow through them. The entire cord is cushioned by a soft substance called Wharton's jelly to prevent obstruction resulting from pressure. Fetal circulatory circuit. Because the fetus does not breathe air, several alterations of the postnatal circulatory route are needed. Figure 5.9a. Also, the fetal liver does not have the metabolic functions it will have after birth, because the mother's body performs these functions. 3 shunts in the fetal circulatory system allow blood with the highest oxygen content to be sent to the fetal heart and brain: the ductus venosus, foramen ovale, and ductus arteriosus. Ductus venosus. Oxygenated blood from the placenta enters the fetal circulation through the umbilical vein. About 1/3 of the blood is directed away from the liver into the ductus venosus, which connects to the inferior vena cava. The rest of the umbilical vein flow goes through the liver before entering the inferior vena cava. Near the end of the pregnancy, the liver needs more perfusion, and 70 to 80% of the oxygenated blood goes to the liver first and then to the ductus venosus. Blood from the ductus venosus, or the portal system of the liver, enters the inferior vena cava and joins blood from the lower part of the body. Little mixing of blood from the ductus venosus and the lower body occurs because it travels to the heart in separate streams within the inferior vena cava. As blood flows into the right atrium, a flap of tissue directs the blood from the more highly oxygenated stream across the atrium to the foramen ovale. Foramen ovale. The foramen ovale is a flap valve in the septum between the right and left atria of the fetal heart. As blood flows into the right atrium, 50% to 60% crosses the foramen ovale to the left atrium. In the left atrium, it mixes with the small amount of blood entering from the pulmonary veins, flows to the left ventricle, and leaves through the aorta. The majority of the blood in the ascending aorta flows to the coronary, left carotid, and subclavian arteries. Therefore, most of the better oxygenated blood bypasses the non-functioning lungs before birth and travels to the heart, brain, head, and upper body. Blood that does not cross the foramen ovale moves to the right ventricle, but flow to the lungs is restricted by the narrow pulmonary artery and pulmonary blood vessels, causing a high pressure in the right side of the heart. Pressure is low on the left side of the heart because little resistance occurs as blood leaves the left ventricle to travel to the rest of the body and into the widely dilated placental vessels. This difference in pressures between the right and left atria allows blood to flow through the foramen ovale. Pulmonary blood vessels. Blood from the superior vena cava and the less oxygenated blood from the inferior vena cava flow into the right atrium, to the right ventricle, and into the pulmonary artery. Most of the blood passes through the ductus arteriosus to the descending aorta, and 10% to 12% of the blood goes to the lungs. After 30 weeks of gestation, the amount of blood to the lungs increases. Blood flow to the lungs is limited because the pulmonary artery and other blood vessels are constricted, causing high pulmonary vascular resistance. Blood perfusing the lungs returns to the left atrium by the pulmonary veins. Ductus arteriosus. The ductus arteriosus connects the pulmonary artery and the descending aorta during fetal life. Dilation of the ductus arteriosus is maintained by prostaglandins from the placenta and low oxygen content of the blood. Changes in blood circulation after birth. Fetal circulatory shunts are not needed after birth because the infant oxygenates blood in the lungs and is not circulating blood to the placenta. As the infant breathes and the lungs expand, blood flow to the lungs increases. Pressure in the right side of the heart falls, and the foramen ovale closes. The ductus arteriosus constricts as the arterial oxygen level rises. Persistent hypoxia may cause the ductus arteriosus to remain open for a prolonged period. The ductus venosus constricts when flow of blood from the umbilical cord stops. Transition to the postnatal circulatory pattern is gradual. Functional closure begins when the infant breathes and the cord is cut, removing the placenta from the circulation. The foramen ovale and ductus venosus are permanently closed as tissue proliferates in these structures. The ductus venosus becomes a ligament, as do the umbilical vein and arteries. Multi-Fetal Pregnancy. The incidence of multi-fetal pregnancy, multiple gestation, has increased in the United States. Much of the increase is a result of a rise in maternal age, when women naturally are more likely to have twins, and infertility treatments that induce multiple ovulation. Twin births in 2013 rose to 337 per 1,000 live births. Okay, I just looked that up because that statistic sounds crazy, and that is in fact a typo. It says 337. It should be 33.7 per 1,000 live births. The rate of triplet and higher order multiple births has fluctuated in the recent past. After reaching a peak in 1998, the rate declined to 119.5 per 100,000 births in 2013. Twinning is the most common form of multi-fetal pregnancy. The same processes that occur in twin pregnancies also may occur in higher order multiple gestations. Twins are often called identical or fraternal by lay people, but are more accurately described by their zygosity, or the number of ova and sperm involved. The two types of twins are monozygotic and dizygotic. Monozygotic twinning. Monozygotic twins are conceived by the union of a single ovum and spermatozoon, with later division of the conceptus into two. Monozygotic twins have identical genetic complements and are the same gender. However, they may not always look identical at birth, because one twin may have grown much larger than the other, or one may have a birth defect such as a cleft lip. Monozygotic twins have a higher rate of birth defects, preterm births, and low birth weight. Monozygotic twinning occurs essentially at random, about 1 in 250 natural, non-assisted pregnancies, and a hereditary or racial component is not well established. Monozygotic twinning occurs when a single conceptus divides early in gestation. The blastocyst in most monozygotic twins is formed with two inner cell masses instead of one. If this occurs, the fetuses usually have two amnions, inner membranes, but a single chorion, outer membrane. If the conceptus divides earlier, two separate but identical morulas and then blastocysts develop and implant separately. These monozygotic twins have two amnions and two chorions, although the placentas develop separately. They may fuse and appear as one at birth. The chorions also may fuse during prenatal development. Examination of the placenta and membranes after birth may not identify whether twins are monozygotic or dizygotic. Tests such as DNA analysis or detailed blood typing may be needed to determine whether twins are monozygotic or dizygotic. Late separation of the inner cell mass may result in twins having a single amnion and a single chorion. These twins are more likely to die because their umbilical cords become entangled during pregnancy. Incomplete separation of the inner cell mass may result in conjoined twins. Dizygotic twinning. Dizygotic twins arise from two ova, fertilized by different sperm. Dizygotic twins may be the same or different gender, and they may not have similar physical traits. Dizygotic twinning may be hereditary in some families, presumably because of the inherited tendency of the females to release more than one ovum per cycle. Women of some races are more likely to have dizygotic twins. Infertility therapy increases the incidence of twins, usually dizygotic, because induction of ovulation often results in the release of multiple ova, with implantation of more than one zygote in the uterus. Women who conceive after age 40 years also have an increased incidence of spontaneous dizygotic twin births, because multiple ova are more likely to be released near the climacteric. Because dizygotic twins arise from two separate zygotes, their membranes and placentas are separate. The membranes, the placentas, or both, may fuse during development if they implant closely. Dizygotic twins are not conjoined because they do not involve division of a single cell mass into two, but arise from two separate conceptions. High multi-fetal gestations. Pregnancies resulting in triplets or higher may arise from a single zygote or a combination of a single and multiple zygotes, or each may arise from a separate zygote. High multi-fetal pregnancies pose greater hazards to both the mother and her fetuses. The incidence of long-term handicaps is higher as the number of fetuses increases.